For joining us. We're here to talk to you about your care, your views, redesigning our sites and services. And I'm really pleased to have two very special colleagues with me tonight. So I've got Dr. Tom Galliford, and Tom has recently been appointed as our Deputy Chief Medical Officer, and Fran Gertler, our Director of Integrated Care. And there will be time to ask some questions at the end of the session, and Tom is going to present half of this presentation with me. So we're using Zoom, as you know. Your microphones will be muted, and we ask you to keep your camera off as this helps with bandwidth. If you want to ask a question, please send it to West Herts Communications, and if you can, please keep your question related to the topic tonight. So those are the questions that I will prioritise, and other general questions I will come on to after that. We are recording this session, and it will be available on our YouTube account. So just to give you a little bit of background, I know some of you have been to some of these sessions, so you will be familiar with this, but for new faces out there, just to recap, we've been working really hard for many years now to secure enough funding to make a really significant difference to the facilities. So we want to massively improve the facilities at Watford General, Hemel Hempstead and St Albans City Hospitals. In September 2019, the Prime Minister Boris Johnson announced that we were one of 6 trusts in the Health Infrastructure Plan. Now that name has changed a little bit, and it's now called the New Hospital Programme, and we are one of 8 front runners. So we're absolutely delighted to be in that position. But it's not just as easy as the Prime Minister announcing that we're in a wave of hospitals to be redeveloped. We have to work really hard now on our outline business case to make sure that we can submit a really strong case for all the money that we think we need to our regulators. And there are many regulators who will be looking at our application. So there's NHS England, NHS Improvement, Department of Health and Social Care, and the Treasury. And what they will be looking to see is that our business case is affordable, it offers value for money, and that it can be delivered soon. And the timescale that we are looking to bring these new buildings to you is 2025 or soon after. So Your Care, Your Views, it's a name that may be familiar to some of you because it might remind you of Your Care, Your Future, which is an engagement programme that was run a few years ago between us and Herts Valley's Clinical Commissioning Group. And the reason its name is similar is no coincidence. We really wanted to reflect that some of the aims of our proposals are the same as those aims from Your Care, Your Future. So very much about providing care closer to home, where clinically appropriate, and also looking at preventative medicine and healthcare and how we can keep you healthy in your own homes without needing hospital admission. We are developing our proposals for our services alongside plans for our buildings. And we want to hear your views on our proposals by completing our online survey. There's only a few days left, so in these lockdown times, you've probably got more time at your disposal than you would normally have, so that's the perfect activity for your weekend. And there are some documents as well, so lots of reading, as little or as much as you want. So there's a strategy document which will really guide you on how we've made our decisions, what national and local strategy we've used. And then there's a clinical brief which goes into a lot of detail about services, suggesting where the services will be delivered from. And there are 2 engagement documents, including a summary document if you just want a quick read. So driving our proposals is a wish to really redefine the role of our three hospitals. So we say three's company. We know the phrase is two's company, three's a crowd, but we actually think that our three hospitals really complement each other and can work together far better than they do at the moment. The broad outline for our three hospitals is for Watford to be the site for our emergency, specialist and complex care, for St Albans to provide planned surgical care, planned cancer care and an urgent care service. And the asterisk there just reflects the fact that we know that the minor injuries unit is currently closed and our plans are to deliver an urgent care service from that site in the future. Hemel Hempstead Hospital, which we will talk about a lot this evening, will be the site for urgent and planned medical care and for treating patients with long-term conditions. And to consolidate and not duplicate is another phrase really that sums up a lot of work that is going on behind the scenes and really reflects what our clinical staff told us when we knew we were getting closer to having significant investment and could make some big changes to our estate. It was a great opportunity to ask them how they thought we could improve the services that we deliver. And so really what we want to do is to group our staff in greater number together along the lines of the service that they provide, so that each site has the right staff and teams in place and the right equipment to deliver the service. And what we don't really want is to continue stretching our staff across three sites. This can really impede good training and development. It means that junior staff don't always have access to senior clinical staff. They can't get a second opinion always when they want one in a hurry. And so we really want to change that and have our staff working in stronger teams together. Also, by having strength in numbers, there's far less risk of appointments or clinics being cancelled due to unexpected leave. And we really think this is a better way to have our staff working together to deliver the services for you. There are two underpinning enablers really to help us make all of these changes. And the first is digital. So just like we are speaking tonight using an online platform, this is something we've really switched to, not just because of the advent of COVID. It is something we were planning anyway, but of course, COVID has really changed the way that we work massively. And you may know that we were the first trust in the UK to have a virtual COVID hospital, and that relies heavily on technology. For instance, patients can upload their health data by using apps or simply typing their information into a computer, and then that reaches the clinical team looking after them, and it allows us to monitor you and your health and to trigger whether or not we need to call you or whether we need some other intervention. And digital also means our electronic patient record, which is something that we're increasingly excited about because it's beginning to feel very real. We're having hardware and software updates the whole time. There's been roadshows running recently, which have had really great attendance from our clinical staff. So the appetite to move away from paper and onto digital systems where we can share information more easily with your permission is really exciting for us. And that will really revolutionise the way that we can deliver care. Feedback so far to virtual appointments has been really encouraging. We are really finding that on the whole, patients are happy to engage in this way. We know it's not right for everyone and you won't be forced into communicating online, but for those people who have been doing that recently, they are reporting that it really is working for them. Diagnostics as well, another really important strand of what we want to do. We can't make the changes we want without really decent diagnostics and upgrading and also providing new in some cases. So that's another aspect of the work that will happen actually before 2025 and 2026. So although we have that as a date, please don't think we're going to wait to that time and then make all our improvements in years to come. We are actively working on all these things all the time, and some of these changes that I've talked about have already happened or are happening. So we're going to continue working towards delivering better care. And you can see some of the changes there. So we'll have a DEXA scanner at Hemel Hempstead, and we will be upgrading all of our diagnostic equipment as needed to get ready for working slightly differently across our 3 sites. So I'm now going to hand over to Dr. Tom Galliford. Over to you, Tom.
Thanks, Louise, and thanks to everyone attending. I suppose I'll just reiterate some of what Louise said, in that it's really important to recognise the proposals in the line with our clinical strategy, which is on the website for viewing, because that's the document that has taken some time to develop, but has been led by the clinical teams, and I suppose I represent one of those clinical teams here. And the reason that we're talking about Hemel Hempstead Hospital first is because up until very recently I was the clinical lead for the diabetes service, and integrated care is very much something that I'm interested in, and I think that this is what is a real exciting proposal of what will happen at Hemel Hempstead and diabetes. So it has to provide urgent care services, so that will continue, but it's looking at groups of people who have long-term conditions, and so diabetes would be one of those, and rheumatology, for example, would be another. And so we're looking at people with a different mindset perhaps, and saying that these are individuals who have long-term conditions but are not necessarily ill, and so actually seeing them in a different area where they can have all the access to the service that are needed in a multidisciplinary setting, it has got to be good for patient care. It's certainly much more efficient, and we've worked in multidisciplinary teams of the like for a while in diabetes, and so having a base at Hemel would seem to be a natural progression. To do that, we need to have other services that we work with and diagnostics, and that's what we would propose. And so we'll have everything at our fingertips so that we can see people and investigate them and treat them efficiently in teams, in a one-stop shop type way, where you see a number of people and you get the problem solved. We'd also like to continue working with our other providers in Herts Valley, and we do this in diabetes. So health and well-being support is a really important part of management of long-term conditions, because psychologically these conditions affect people as well. And I mentioned that we like multidisciplinary teams in diabetes. That's doctors, specialist nurses, dietitians, psychologists, possibly in the future retinal screeners, all bringing it together so that, and podiatrists, of course, for checking feet. So bringing it all together so that we can really provide the best possible care for our patients. We've talked, thank you, that's fine, next slide, it's great. So we've talked about diabetes and we've talked about rheumatology, but actually the proposal will be to look at most specialties have got a long-term component, and actually the same rules apply. We may have been the first one to board this bus, but actually if you look at other hospitals and other care models, then actually this is now widespread, and it's the way that the futures of all hospitals will go. And that's part and parcel because people are living longer as well. So chronic conditions become, unfortunately, more the bread and butter of our work. So we're talking about cardiology here, dermatology as well. And this is focusing their care at the Hemel Hempstead site. And then at the last, we're just going on about the clinical hub for diabetes services. And of course, this is incredibly attractive, and I think there's another thing that Louise mentioned is that COVID's taught us so much, but actually we don't want our patients, and our patients with diabetes are particularly affected adversely by COVID. We don't want them in an area where they're exposed to danger. And so managing patients in an outpatient setting or at an acute setting, so-called hot hubs, is the way forward. And that's been shown in other countries. Next slide, please. So we've mentioned diabetes and a few rheumatology, similar plans here, one-stop model of care with their specialist services, bringing most of our patients to the Hemel Hempstead site, keeping our patients away from emergency care at Watford, and then collaborating with other providers in Herts Valley. So that's primary care, GP surgeries, community pharmacies, community services, and we work very closely with Hertfordshire Community Trust and CLCH, Central London Community Healthcare, I think, HPFT, who are the mental health services, and then our social care providers as well. So we're talking about integrated care models, and nowhere is this more necessary than for the elderly. And again, there's been some very good models of care for frail elderly and for elderly people that we need to adopt if we're going to really provide the best standards of care for our patient groups and keeping them out of hospital. And by hospital, I mean acute hospital. Next slide, please. Thank you. So, of course, that's Hemel, but of course, we have other sites, and we need to tell you what we're doing, plans to do about them as well. So whereas medical outpatients and long-term conditions will rest in Hemel, then surgical specialty outpatients will move to St Albans. And so you've got there where we provide elective surgery at the moment, so routine operations. We've got an opportunity to provide a really strong planned care for surgery, and unfortunately, we know that often involves cancer services as well, because they need operations for removal of cancers, and so we can tie those together much closer. Diagnostics are part of that as well, and gastroenterology form a very important part of the sort of the esophagus and the guts and the bowels in amongst all of that. And so they need to be part of this new surgery cancer service, but at the same time, they're also needed in the acute hospital, so they'll have a footprint in Watford General, and also it looks like it's very sensible to have some endoscopy facilities at Hemel Hempstead as well. Now, this also, as it happens, means that we can redevelop our gastroenterology services and improve it, and that's particularly given that the site at Hemel is just a little bit too small for us, and that's outside. Monitors are noting this as well, so we can use this as an opportunity to improve services across the patch. Next slide, please. So I've talked a bit about diabetes. Sandeep Ballara is a consultant rheumatologist, so both him and I were originally appointed to Hemel Hempstead, so we've got a vested interest, so to speak, and he has a similar mindset. So, and this is his quote: "In creating a base of planned medical care at Hemel, we can see our patients can see a range of clinicians all under one roof." And he makes a very good point that great hospital care doesn't just mean great acute hospital care or emergency hospital care. It can be in a place that is removed from that. And that has got to be a better patient experience. And it's, as we know now, post-COVID, it's safer as well. Next slide, please. Thank you. And then this goes on about St Albans. So we're talking about the improving the surgical services here. We already do planned surgery, but we can improve that. We can increase that, which means that our patients won't be waiting so long for operations. And again, our trust, thankfully, has done very well compared to others in our region and nationally around the COVID times. And that's to try and keep some operations going. And we've done that. We haven't done as much as we would like, and that's really terrible, but we've done better than a lot. And that's because we've had a hospital at St Albans where we can remove our patients from the acute site, which was hit very hard by coronavirus, and still provide emergency surgical care. To do that properly, we need the equipment there, and we need imaging, and we need diagnostics. And so we've talked about endoscopy, but also nuclear medicine is better provided there. And as well, we need to think about urgent care for residents of St Albans so that they also have access to emergency services. Of course, when we talk about cancer services and gastroenterology, we're also moving nicely into this idea again of a one-stop clinic where you get all your investigations and consultations in one visit, and that this provides us an opportunity at St Albans for this as well. Next slide, please. And this is Freddie Banks, who's a consultant urologist, so he's a surgeon, and I think he talks about that, and I won't read the first bit of what he's talked about, but he's saying with the right diagnostic equipment and clinical teams in place at St Albans, we can reduce the worry and the wait for so many patients, and that really is another sort of view, or important to recognize that this is for patient care and better patient care from a surgical perspective. Next slide, please. And then there's Watford General, and I think that everyone who's been to Watford General would appreciate that its estate is tired and needs to be developed. And this is not a small undertaking. It would become the acute site, and it needs to be better at improvements in emergency and specialist care service with an urgent treatment centre as well as the A&E department. A larger emergency department, which is too small at the moment, as many of you may have experienced, that we can look after people and provide the right care. And that's complex diagnostics, that's fracture clinics, that's critical care, that's ITU, and what you'd expect from a modern acute hospital, which unfortunately we're struggling at the moment with that. It needs to have the right access for patients. And so it needs a new multi-story car park, and then actually looking towards the future and what we're going to be looking for all of our patients in this area, in which we rely on other hospitals, tertiary centres, or people going into London, or what is currently Mount Vernon Hospital, and that will change as well. So we're looking about neurology patients, chemotherapy patients, additional cardiology, so that our residents don't need to travel outside of our locality to get the care that they need, to get the specialist care that they don't get at the moment and really need to get. And of course, with that, we mustn't forget about the women's and children's services, which is an important part, but make sure that we're delivering that, and it's a nice, safe place for mums to give birth as well, and for children to be looked after. And this is Vicky, who's one of our intensive care matrons, who has been through the wars recently. And I think she's underestimating what she's experienced in the last 12 months with COVID. And she makes this point that it's taught us a lot about managing patients and how we can do it in the future. So from her perspective, it was the increase in critical care beds that we needed, and she was part of the team that saw that. And we didn't have enough space, and we didn't have enough critical care beds, and we need more. And then having a COVID-free site, which would not be the Watford site, to also look after patients. And so she makes the point there that this has got the engagement and the support of staff, and we're really excited about it. And that's for a number of reasons, but most importantly, because it allows us to provide better care for our patients.
Thank you, Tom. Thank you. So this is just where we are with our engagement. You can see that we are coming towards the end of our first period of engagement, which means we really do want to hear from you by completing the survey. And if you do want us to come and talk to you, if you're part of a group in a community, then you need to get in touch really, really quickly to enable us to come out and speak to you, but we're happy to do so. And we will pause during the run up to the local elections. And during that time, we will consider what people have told us through the survey results, and anything that we feel we need to clarify where it's become clear that we haven't been clear enough, we will do that, and we will address areas of concern in our second period of engagement. And all of the feedback goes into a report which is given to our trust board so that they have a good opportunity to consider the voices, the opinions and the views that we've heard along the way. The survey that I mentioned has been commissioned externally, so I'd like to think we're good at providing care, but surveys probably isn't our strong suit. So we've had that devised and road tested before we launched it. So that's been created by an independent organisation, and they will also manage the analysis of that. Lots of different ways to get involved. So as I've mentioned, the survey, it closes on Wednesday at midnight. And if you do have time to look at our website, that would be great, because as Tom said, a lot of hard work has gone into those documents. They really are the voice of our clinicians putting onto paper their views for the future of our services. So please do look on our website, share our survey. I think the QR code is coming up shortly. So if you hover over your screen with a mobile phone, you would be able to find that. So let's just see if that's the next slide, or the one after. There it is. So so you can find it that way or via our website. I've noticed there's a few questions coming in, so we're going to go to questions now, and there's some good ones about the one-stop clinic. So I think this is probably something that, Tom, you will start the answer, and Fran, you may want to come in. But in practical terms, how many different specialties do you think could be built into one appointment for a patient at Hemel Hempstead? Tom, if you could start off with that.
Yeah, thank you, Louise. Good question. So I think the best thing is to answer it from my perspective. So if you look at diabetes, which is a multi-system disease, so many different parts of the body are affected by that. So I think that there's a real opportunity here. We do a bit of it already, and we can expand it. So at the moment, for example, if one has a foot problem, then I would like a patient to come and see a podiatrist to get a foot check. I would like them to see me, who can look after their diabetes, hopefully, and take an overall opinion. I would like them to see a vascular surgeon who can advise on whether they need something doing with their circulation. I'd like them to see a dietitian to advise them about their diet. I'd like them to see a diabetes nurse who can support them with blood sugar testing and maybe some medication things. But to do that as well, I would need to have some investigations performed. So I would want an X-ray of the foot and possibly a look at their circulation in more detail, and then possibly even further imaging such as an MRI. So that would be something that we do in part at the moment. And I think that the opportunity there is, you're saying, okay, that's an awful lot of checks, actually. And at the moment, we do it, but it takes time because we may not have access to a vascular assessment at Watford General where we see this person. So we need to go, they need to have an appointment in a month's time or a week's time or whenever with the vascular surgeons at another site. So we're saying bring it all together. So I think that would be an example of a really good multidisciplinary team, and that's in diabetes. So without knowing too much more about rheumatology, I think there would be a similar thing of saying someone's got a joint problem and they would need to see someone to assess that joint. That would need imaging as well. They would need some care around that joint, possibly dressing or support. That would be possibly with an orthopedic surgeon who's come to the clinic, possibly with with some specialist nursing on that. They may need their medication change, which again, specialist nurses would be involved in. They may need that joint injected. That would be another diagnostic. So that, so I think that the opportunities are there. Another very quick example is in my specialty, which when it's not diabetes is endocrinology, which is the study of hormones. And we see people with thyroid problems. And again, a one-stop shop would be come in, get an assessment, see a doctor, possibly see a nurse, see an X-ray doctor, get an ultrasound scan of the neck to look at the thyroid gland, get a needle put into the neck if we want to biopsy something, get the result then and there. And then you have a discussion about what the next steps are. So this is a really good way of working. It is, as people probably realize, is incredibly efficient. But I think that also, that's not just from us churning through the patients. It means that you've got fewer visits to and from. You've got an answer. You've got a focus of where to go. You've got a diagnosis, and therefore you can then go on to think about treatment. And that's got to be better. That's what, if you're designing a hospital these days from scratch, that's what all the modern hospitals are doing in America, on the continent. We're a little bit behind that in the UK, if we're honest. And this is bringing us back into line with our colleagues overseas, I think.
Thank you. Now that's going to be quite hard to follow, Fran, because that was a very passionate endorsement of everything we're trying to do at Hemel Hempstead. But your role includes lots of reaching out to other organisations that we work with. So could you say something about how other organisations can feed into the model at Hemel Hempstead for the benefit of our patients?
Sure. So I suppose it's about that end-to-end care pathway, isn't it? So before patients arrive with us and then getting them back home again. So although this is all about planned care and things that you'd be coming in for an appointment, there will be patients that will require other services to wrap around them, whether they be social care services, voluntary services, getting patients back out into the community and being well supported into the community. So that opportunity of having somewhere that we can use as an overall hub to wrap all the other parts of care around our patients, and particularly around that preventative agenda, I don't think we can underestimate the opportunity we've got there.
Thank you. And can I ask, this is probably one for you, Tom, but for some people with long-term conditions often have acute exacerbations requiring 24/7 medical care or supervision. So an example might be IBS, IBD, Crohn's, UTIs, cellulitis, frailty. So those things that can't be sort of taken care of in a few hours. Would they be treated at Hemel and then move to another site? Or for that kind of patient, would they go somewhere else to start with, do you think?
So I hope I answered this question properly. I think that if we're saying that someone's really unwell, then they need to be in an acute site. I would say that I'm a hospital doctor, but I wouldn't want, they need to be looked after by not just doctors, but nurses as well, and all the auxiliary care that we provide to make sure they're safe. And that's got to be the priority, I think, in the first instance. I would like nothing more than to sit at Hemel in my multidisciplinary clinic and not have to come and do anything else. But I do have this other role, which is doing medicine as well. So we will still be having, diabetes doctors, endocrine doctors, gastroenterologists on the acute site. It's just there's not going to be as many of them as there would be in the sort of planned care setting. If we're then talking about whether we think that someone needs maybe not to go into a hospital but needs more support, then I think that that's because of perhaps their diabetes. And I think that's where the opportunity really is to sort of move into what Fran was talking about and saying, actually, if you've got the ability to liaise with other services because they're all on one site and do this wraparound care bit of work, so work with other providers, so the community service, and get that going, then at the moment, again, that's pretty hard to do. And so looking at that and saying, well, downstairs or level 1 or floor 1 of the Hemel Hempstead is not the diabetes clinic, but we've got this really good frailty unit that we can start and get, because this person actually needs that to get them home, because we're actually talking about keeping people out of an acute hospital. Then that absolutely is something that we should be doing. We do a little bit of it, but I think Fran may be able to say a bit more, but that is definitely the model that I perceive going forward. Although my expertise is perhaps more in the diabetes world than in the wraparound care world.
Thank you. Did you want to add any more, Fran, to that?
Why don't we see what else people want to, I'm happy to come back to it if we want, but I'm sort of aware there's probably lots of other points people want to raise.
Sure, thank you. Yes, there is a question about a new MRI at the Hemel Hempstead site. Yes, that is in our plan. No, we don't know exactly where on the site it will go yet, nor do we have a plan for exactly on the site the UTC, so the Urgent Treatment Centre, will be located. So our plans are evolving for all 3 of our sites. And that brings me on to quite an important point, really, because on the 26th of March, a public consultation is launched on the outline planning application for Watford General Hospital. So that hospital will take a longer planning process, but it doesn't necessarily mean that we will prioritise the work on that hospital in terms of timeline. So the improvements that we plan for Hemel Hempstead and St Albans might be delivered before the work at Watford General is completed. But for anyone who has a particular interest in Watford General, then the 26th of March is the day that the public consultation is launched on the outline planning application. So that's a sort of technical consultation, and it is managed by the architects. And once that has been launched, then the architects will begin to, or they will continue their work on the Hemel Hempstead and St Albans sites, which have a quicker planning route, we expect. So I've been asked also about parking. So I will just address that in saying that we don't plan to expand the parking at Hemel Hempstead and St Albans. So the question was, what about the parking at those 2 sites? If we can improve it, we will, but it's not a big part of our plans at the moment. And the St Albans site doesn't have a lot of extra land for us to do that. And so that isn't in our plans. And what you've heard Tom say was quite important about fewer visits. So we are hoping that there will be less journeys overall. And as we saw on one of the earlier slides, we are looking to take out around 200,000 outpatient appointments every year, because we are converting so many appointments to digital, and other services that were or are currently on hospital sites are moving to community settings. So we are hoping that our sites will have a bit less traffic on anyway. And of course, we will be working to deliver the NHS commitment to net zero carbon, and encouraging people to use other methods to get to hospital. And that might be working really hard with our staff so that they can get to hospitals in other ways than using the private car. So no big plans for parking at Hemel Hempstead and St Albans at the moment. So I should just go back and see if there are any more questions on the clinical service. There aren't any at the moment, but we ought to make good use of having Dr. Galliford with us. So if you have clinical questions, please do send them in. I've been asked a question here about the buildings and the buildings that are currently disused at Hemel Hempstead and improvements to the overall environment. As I understand it, the buildings that are currently mothballed are not part of our plan, so we don't intend to spend money on reusing those buildings, because we don't believe that's economically a good idea. What we want to do is free up land on that site for regeneration And so we will be having discussions with Dacorum Borough Council on how that land can be best used to help the regeneration of the town centre. So I'm looking to see if there are any more clinical questions here. Again, there's a question which I think is quite hard to answer at this stage about where clinics will be located and about the walkway between the old building and the Verulam building. And I can't answer whether we expect patients to use it, but we can have further sessions when we have more drawings and more plans. So although we are stopping for PERDA for the elections, there's nothing to say that when we don't have plans in the future, you know, we can come back out and share those with you. So I have a question here about one-stop pathway, and it suggests that people might mean that they might have to stay from the morning through to the afternoon. And does that mean that departments will operate morning and afternoon only? So I don't know if that question means that we will, whether or not we will work into the evening, but I think the point is we will try to fit our services around the patient. I don't know, Tom, if you've been having any discussions about extended days. I know, for instance, that we often do surgery on a Saturday, but is there anything in the medicine model that moves into the evenings or weekends, do you know?
So there's definitely part of the sort of NHS plan is about hospital services being 7-day services. So not just weekdays and weekends. So it's providing hospital care every day of the week. And obviously that needs to be factored into any future plans. We're going to have new hospital sites, and the workforce with the extra resources that we have, I suspect, will be consolidated. And certainly if we're having to provide more care on other days, then I think that we will inevitably have to look for an expansion of doctors and nurses, and but I think that probably will also become a really attractive site a more attractive site, I should say. I'm here already, but you know, a more attractive site for people who have qualified and want to come and work here. I think that really is. It sounds silly, but I think that does matter for people who want to put down roots, to make sure that, you know, the place they work in is nice and provides good care. So I think we should assume that it'll be morning and afternoon and possibly into the evening 7 days a week in the future. Whether it'll be how long that is, I don't think there's been any discussions about it. There'll be separate contract discussions at a national level for all the workforce, but it will definitely be looking, I would guess, at 7 days at the very least.
Thank you. Fran, can I come to you and ask you about clinical involvement or involvement of other organisations? So Tom's said that the plans that we're presenting to you tonight have got really good clinical engagement. Can you sort of give a flavour of how we've broadened that out to other organisations that we work with? Thank you.
Sure. So we're not a standalone organisation, and our patients don't have standalone needs. So we're continually working across a variety of services to ensure that everything is covered for patients. So in terms of that working, we particularly with our community services, I think is probably the best examples that I would give. These are about end-to-end pathways. I know I've said it already, but it is very much about patients before they come into us, making sure they're optimised and that their care is then followed through. So it has to be a single way of working. And ideally, from a patient perspective, you shouldn't actually notice which organisation is delivering your care. It should be that you are receiving care for whatever it is that you need, and it might be provided by a number of different providers or a number of different staff. And the keys that we talked about right at the very beginning in terms of the benefits of having electronic patient records, which will allow your care to be shared with other services, including being able to have some of that delivered in your own home, I think is probably the key part. But these are absolutely, we work hand in glove with our partners. I mean, never more so than over the last year, in terms of how we've needed to manage the totality of the challenge that we've all had. So this is not about standalone. This is absolutely around our GPs, our community services. They're completely involved in the decisions and proposals that are being put forward here.
Thank you. I'm just about to ask my last question. I'm very surprised because I've been doing these for some days now. We've not run out yet. So I'm going to ask the last question that I've got. But if you do have another question for us, then you do need to send it now via the chat function to West Herts Communications. And the last question, I'll attempt to start the answer, and then maybe Fran and Tom will chip in. But it's about staffing. So the question is that we've heard about more services, but does that mean that we need more staff, and where will they come from? So I'm going to have a go, but would welcome some input. Yes, we've talked about more services, but we've also talked about different services. So a lot of this is about how we reorganise ourselves and how we become more efficient. And we do think that the advent of the electronic patient record will really help our efficiency. And so we hope that we will have more time to care, so that will release time to care. That's really the ethos behind the electronic patient record, as well as accuracy, so and patient safety. So we think it will also have a benefit of giving our nursing staff and all our clinical staff more time with the patients. So we don't worry unduly that we can't get staff to to run these services. We did have a 0% vacancy rate for our Band 5 nurses not so long ago, and being voted the UK Employer of the Year by the Nursing Times is also a great boost for us. So we do find that recruitment and retention is reasonable for us. It's certainly not something that we worry about. And I think also, Tom, consultant posts, we always get plenty of applicants, and our vacancies for consultants is normally under 10, so it's in single figures. Is that your experience?
Yes, I mean, I think that obviously I came here, and there were quite a few people wanting to work at West Herts, and that was 10, 11 years ago, and we haven't had a problem from a doctor perspective in recruitment. When jobs have gone out, there's a few specialties that have traditionally in the country have always struggled a little bit. So accident and emergency, we know there is a shortfall of that particular workforce, but generally I think that that there isn't a problem with attracting doctors here. I think that again that we've done always pretty well regionally from a nursing perspective and an HCA perspective and in the allied healthcare professionals. I think there is also a national conversation going on at the moment about, and if anyone on the audience has got any influence, then I think it's about valuing the workforce in the country. And I think that that's where I think there's quite, we've been attractive, and it's in our gift to make our work, our place of work attractive for our members of staff and recruit, and we've recruited very successfully overseas as well. But I think that there is a bigger question here, which is a national question about how we get people wanting to work in the NHS with all the challenges that it faces. And so, it's in our gift to sort out some of that, but not perhaps all of it.
Thank you. So I think I now have probably enough questions, but do keep them coming, and I will try to pick out the ones that relate to tonight's presentation. So along those lines, Tom, there is a question about how we will encourage clinical staff to choose to work at Hemel Hempstead. Do you think that will be a problem? And do you see a bias that people want to work on the Watford site or the St Albans site?
So I think that, well, first of all, you work for West Herts, so you work for the organisation, the same as I was recruited to Hemel initially with sessions in Watford and St Albans, and I've always really worked on all three sites. So you work for the trust. The bias comes about where you're best going to support and serve your patient group. If you are going to be an intensive care doctor, then that work is going to be at the acute site. If you are going to be someone who's involved in chronic disease management, then you will want to be somewhere where you can provide the best resources for your patients. And with the proposals that we have, it's Hemel. And to be honest, if we went back 10 years, I'd bite someone's hand off if they said you're going to be appointed as a diabetes doctor and you're going to have your own diabetes area that you can do all one-stop shops at a site. I really wouldn't mind where that site was. If it wasn't on the acute site, I'd probably prefer that, because it means that I wouldn't have that that in the background to worry about, or I'll be there just for my patients. And I think most medical specialties, when they're doing their actual specialty that's not an acute medicine thing, would prefer to be at a site away from where accident and emergency is, where inpatients are, so that when we're doing our inpatient work, we're focused on that. And when we're not doing our inpatient work, we're focused on our specialty. The surgeons definitely would be in the same boat as that. If you could say you can do your operations, which is good for patients and what you're interested in, and that's, you're not going to have to do anything apart from be sitting at St Albans and doing that 9 to 5 every day, they would also bite your hand off, because that means that they're providing their expertise and their care for their patients in the best possible way, and they're not being affected by what's going on the acute site.
Thank you, thank you. I've been asked this is a really good question about will St Albans and Watford residents be using the long-term condition facilities at Hemel Hempstead? And I'll start off, and again, if Fran or Tom want to come in, but the answer to that is yes, because that is where we are hoping to create a centre of excellence around long-term conditions and planned medical care. So a range of outpatient services will be provided at all 3 sites, but that will be just the high volume outpatient services and those where it's really good for people to get them as locally as possible, antenatal being an example. But for anything that is more specialist, especially if you need the input, as we've been talking about, of more than one specialty, then we will be creating the perfect place for you to go at Hemel Hempstead. So we do understand that means some additional travel for people. And our plans are around providing the best care, and that isn't always going to be the care that's in the hospital closest to you. And that's an important point. And alongside that is our commitment to work with travel planners, the local authorities and transport providers to really understand the impact that may have for some patients, and to do what we can to alleviate any difficulty that comes from travelling to a different site. There's another question about staffing, which, oh, sorry, Tom or Fran, did either of you want to add anything onto that?
So I was just going to add in again, just in terms of accessing care isn't just about attending a site now, and the opportunity would be around having virtual consultations with a number of professionals as well. So whereas we are saying we're concentrating in one area, the traditional ways of delivering care where everybody came to us, I think is quite different now. And so we probably need to factor that part in terms of, for some patients, and I recognise that this isn't the case for every patient, but there will be opportunities for video or telephone consultations, which will also support, as well as them being able to initiate their appointments when they need them, rather than sort of the more traditional ways of we'll send you an appointment for every 6 months or whatever.
Thank you. Yes, that's a really good point. So the patient initiated follow-up is a different way of requesting a follow-up, which will also mean that follow-up can be online. So yes, there will be some travel, but as Fran says, a lot of our interactions with patients will be online. Another quick question here about London waiting, which is the higher rates that staff are paid if they work in London, and the question is, does that make it difficult to recruit staff to Hertfordshire? Well, it doesn't help, but a lot of people choose to work in Hertfordshire because they live in Hertfordshire and they like the quality of life of being out of London. And, you know, referring back to what I was saying about a 0% vacancy rate, we have done a lot of good work to encourage people to come to West Herts and, more importantly, to stay at West Herts. So if you look at any of the past sessions, David Thorpe and Tracy Carter both talk a lot about all the programmes there are for nursing associates and healthcare workers and nurses to progress their careers within West Herts without leaving. So that has been really good for us in retaining our staff. So as I said, it doesn't help having London waiting being higher, but it's not really proving to be a big issue for us at the moment. Is there anything, Tom or Fran, that you would add to that?
No, I mean, I would only say, just from personal experience of spending time over on, like, the number of staff that I speak to that are they're local residents, they live around there. That's why they want to work there, and they want to be part of delivering care for their neighbours and friends. Thank
you. Tom?
I'll probably be a little bit less politically savvy here, but I think it's again, what we can control is important to make an attractive place to work, and that counts for lots. And working professional relationships, and indeed our patient groups, who generally, I would say, I really enjoy working in this area. I've always have done. But you know, it is out of our gift. But for lower paid workers, I think it really does matter, and I think it's a real shame that we see people leave on the basis of London waiting being better in other areas, and it's a real shame. It's a real shame because we lose good people, they have invested in our organisation and looked after our patients, and it's a real shame. But it's not something that we can control. We can only try and make it as an attractive work environment for them as possible.
Thank you. This is an interesting question about the new ways of working and whether they will reduce the time from symptom referral to diagnosis and access and treatment. So, Tom, do you think the one-stop clinic model that you've talked about will really reduce the overall wait for our patients?
Oh gosh, I hope so. That's what it's based on. It's based, you know, if we shouldn't be too upset. We should think about what is good patient care. But if you look at myself or my relatives or whatever, you want to have as, if you can get your answer and you don't have to come back to hospital with a solution in one visit, rather than being passed from pillar to post, which I think sometimes, I'm afraid, is the case at the moment. And you can get it done in a timely manner. And you know what that means? That frees up appointments, actually. It means that the system isn't clogged up with multiple appointments. It means it's efficient use of time, but patients do better. And the cancer wait is particularly, you know, is particularly worth thinking about, that of making a diagnosis on where the patient is worried, the GP is worried, and we can allay that fear or start treatment sooner on the basis that you've got the answers there and then. It's a really exciting model that we're trying to pursue. Yeah.
Thank you. And another couple of points here about a concern for people who don't work with computers and might not be very good with technology. Our electronic patient record should flag the communication needs of our patients. So we will be able to understand if those patients are people for whom a phone call or a face-to-face visit is absolutely necessary, and will tell us which patients do not want to interact using, or cannot, for any number of reasons, interact using digital technology. So although we've talked about it helping us become more efficient and being appreciated by those patients who've used it, it is in no way compulsory. So that's really an important message. We don't want people to feel they're railroaded.
Can I just say something on this as well, Louise? Because we do something a little bit similar at the moment already in diabetes. So, you know, if we get a referral from a GP, we get flagged whether that person is able to travel to the hospital, whether they are able to, you know, whether we want to contact them by mobile phone, whether they've got an internet or an email address, and whether we can do a virtual appointment. So I think that this has started working already, and it just, the future is, we've learned a lot, but we need to continue with that. But I think that that is easily solvable, so that patients get a choice. That's what we all believe in, isn't it? That patients get a choice of how they want to see their doctor. Some people don't want to see their doctor and quite happy for a virtual review, and others will want to see it. And that's got to be part of the questions, I think.
Thank you, thank you. Okay, so that rounds off our evening. I would just like to remind you to fill in a survey. If you can make time to do that, that would be great. And also just to flag to you the date of the 26th of March, which is the start of the consultation on the outline planning application for Watford General Hospital. So after this engagement has ended, there's going to be something else to fill your lockdown life. So I hope you will take a look at that also. I'd like to wish you a good evening. I'd like to thank Fran and Tom for being with us, and to wish you a happy weekend. Thank you very much.
Thank you.